Everyone's brain is extremely heterogenic, so it's different. You can put 5 of us in a room, we can all have the same diagnosis of a GBM, but all of ours can be different. They're highly aggressive biologically. It's a small area in a hard cell. Trying to get through the blood-brain barrier is different. There's a lot of areas of hypoxia in the brain. There's a lot of pressure there. The microbiology, like you said, it's just very different. It's a cold environment versus a hot environment.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Lori Cappello, Research Advanced Practice Nurse at the John Theurer Cancer Center of Hackensack Meridian Health in New Jersey, about what oncology nurses need to know about brain malignancies and caring for patients with them. As a reminder, you can earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in today's episode notes. Welcome and thanks so much for joining us today, Lori.
Hi, Jamie. Thank you.
So before we get started, tell me a little bit more about your experience in caring for patients with brain tumors.
So I have been a research nurse that transitioned into an advanced practice nurse for the last 16 years here at Hackensack at the John Theurer Cancer Center, dedicated to neuro-oncology. I also I hold a nurse liaison position for the Alliance for Clinical Oncology Groups in Oncology through CPSU and the NCI. So anyone that participates, any site in the country that participates in one of those trials, if any of the nurses have a question, I am their go-to for questions on the trial or anything in general with neuro-oncology, which I had to actually apply for that position. And I was quite shocked when I got it, but I've now held it for 5 years. And I say sometimes it's a lot of work for my free job, but it was a great learning experience and it's actually a great teaching position as well.
Outstanding. Well, certainly then we have the right person on the podcast today to help us talk through this really important and often not talked about topic about brain malignancies. So to start things off, primary brain tumors we know are relatively rare compared to many of the other cancer diagnoses that we see. So what are some of the more common diagnoses under that umbrella of kind of brain malignancies and how frequently do they occur?
Well, actually, all brain cells are gliomas. I once said to the doctor I work with, I said, God, I feel like they're becoming more prevalent. And he said, no, it's because we're experts and we see so many of them. I live in New Jersey and I'm in the tri-state area. So we're in a heavily populated area. And, we're very blessed to live here because we have really good medical care where we live. And for people in our area, they can bounce from New York to New Jersey. And neuro-oncology is very small, but a glioblastoma actually is the most predominant brain tumor that we do see. It is the most diagnosed of the brain tumors. And then I would say that an anaplastic astrocytoma is probably the second diagnosed. Historically, a GBM, they used to say was probably an elderly patient disease, but we are definitely seeing it diagnosed at a much younger age now. Definitely much more prevalent, for people under 60.
Well, it's funny that you say that. You feel like everyone's getting brain tumors. I felt the same way. My history was in GYN oncology. And I was like, does everyone have ovarian cancer? It feels like everyone, but it's just that, like you said, that's that concentrated, like that's where people are coming for that care because it is so specialized. But certainly interesting, as you mentioned, that we are seeing those diagnoses happen in younger patients. So certainly an important topic for us to continue to talk about.
I don't know if it's because I'm getting older, but.
Right. So let's talk a little bit about how they are found. There is not a screening, of course, for brain tumors. It's not a common practice. Usually I would assume they're incidentally found or there are symptoms. So what does that diagnosis sort of journey typically look like for most patients that you care for?
Unless somebody gets into a car accident or is going for a surgery and has a scan, that's when we usually find an atypical benign meningioma. That is the only time we find a tumor unexpected. Otherwise, it's always based on symptoms. And 9 times out of 10, either a patient out of nowhere has a seizure or they present with what they think are stroke-like symptoms. they noticed that they were slurring or they were becoming more forgetful, or a family member noticed it and said, hey, what is going on with you? But usually they present to the ER. And again, a CAT scan is always done first, and lo and behold, something's seen. But usually patients present with what they think are stroke-like symptoms, unless, they have a seizure and they're brought in.
So sort of a broad question, but can you give us just maybe an overview of what does that sort of the treatment landscape look like for brain malignancies? And does that include systemic therapy, surgery, radiation, or maybe probably a combination, a little bit of everything?
A little bit of both. Surgery is always the best treatment option. It's safe. Safety is always the most important. And sometimes depending on the location of the tumor, we can't always get the best surgical resection. Remember, because it is our brain, depending on where in the brain, you can go into surgery and you come out with a lot of deficits. So if we can get a safe, great resection, that is definitely always the best possible first step. Obviously, we want tissue for diagnosis. We want to be able to alleviate any kind of swelling in the brain, because sometimes if you have swelling in the brain, that can cause symptoms as well. They could even be the cause of what brought you in. That could be something, the swelling in the brain could have been the cause of the symptoms, making you have seizures. And then once we have that information, believe it or not, the safe time to start any kind of systemic treatment is 4 to 6 weeks. And that scares people because, once we actually diagnose the tumor, people don't, the first question is, well, how long have I had this? And nobody knows the answer. So then once you have surgery, to be told that we have to wait, 4 to 6 weeks to start treatment, the first question is, it's going to grow back. Sometimes it does, but it is rare for it to grow back in that time. But of course, we have seen it a few times. But once we start treatment, the next step is of course, a clinical trial. We always encourage clinical trial enrollment because we do need better, more effective treatments for this disease. There just are not enough effective treatments for it. The blood-brain barrier, which is very, very difficult to cross, inhibits good treatments for us. But the standard of care, no matter where you are in the world, is Temodar and radiation, which starts, like I said, 4 to 6 weeks after surgery. And that is given for approximately 6 weeks. And then you have a 1-month break. And then we have a maintenance program for 6 months with that. And then the only other FDA-approved treatment that has come along in the last 20 years is a device called Optune, which it stops cell division. So it's alternating electric fields that stops cell division at the mitosis state. So that is the standard of care, like I said. The brain environment is very, very different than the body's environment, which has made immunotherapy very difficult for trials. There's been a lot of barriers in that field.
Let's talk about that maybe, or just kind of emphasize this. What is it about the aspects of brain malignancies that make them just so challenging to treat?
Everyone's brain is extremely and heterogenic. So it's different. You can put 5 of us in a room. We can all have the same diagnosis of a GBM, but all of ours can be different. They're highly aggressive biologically. Like I said, it's a small area in a hard cell. Like I said, trying to get through the blood-brain barrier is different. There's a lot of areas of hypoxia in the brain, which causes issues in and of itself. There's a lot of pressure there. The microbiology, like you said, it's just very different. It's a cold environment versus a hot environment in the body. And then the pathways are just different. Like the epidermal growth factor that we see systemically, it just doesn't function as the same. So we know that they're the same signal pathways that we have everywhere. They just don't always act the same. And they're definitely more aggressive in the brain.
Well, and you mentioned it regarding surgery, but probably similar in terms of other treatments, like the allowance of toxicity or damage is very narrow because you're in the brain. So, you can't just carve it all out and just hope for the best because that will leave you with significant deficits. Same for toxicities. When you're dealing with toxicities to the brain, that is very different than maybe toxicities with blood counts that might rebound or nausea that we maybe could control with other pharmacologic agents. And so just thinking about what it means to have toxicities in the brain, it's just a different sort of level of severity that have to be mindful of. And that threshold for how much toxicity is tolerable it's very narrow.
Right. And if you think about immunotherapy, when it first was started on trial, or even when it first got it approved, and you think about, let's say specifically Ipi-Nivo, and we started working on it and looking at it in melanoma, we knew sometimes those tumors, we would see them on scans and they would get bigger before they got smaller. And that was okay to kind of let it ride in somebody that had a few lesions in their whole body. But on a brain scan, if you saw somebody that maybe they weren't a dedicated neuro-oncologist, and they look at an MRI and they see, oh my God, these tumors are getting bigger, they're going to switch treatment. But then the next scan, maybe it looks better, when really they should have kind of said, the idea of pseudoprogression in the brain was really scary in the beginning. So I think, a lot of earlier trials failed when maybe they didn't have to. But again, we're talking about the brain.
Right. Well, and I think you bring up an important point of that. Certainly, I'm sure most of our audience knows that metastases of other cancers to the brain are very different than a primary brain malignancy. However, the challenges in treating either of those are similar.
Correct.
I just think that's really important to consider, of just how tolerant we are of toxicities, deficits, things that potentially could help treat the disease, but what do they leave that patient with after the fact? And is that risk-benefit balance, is it the right balance? That I'm sure is part of the challenge.
And actually, you said something really important, because a metastasis to the brain is curable because of the way it lays in the brain, where a tumor that initiates in the brain, the way it's really embedded in the brain tissue, where metastasis is more laying on the tissue, if that makes sense. So they are able to be treated very differently. A breast cancer that goes to the brain, that is not necessarily a death sentence, for lack of a rosier way to describe it. Unfortunately, somebody diagnosed with GBM, any kind of literature you look up, you're going to see the average life expectancy is quite dim. I always try to tell patients, none of us are the big man or woman or whatever you believe in, and none of us should be giving you a timeline. But, and I always tell patients, don't Google anything, because anything you Google is going to be old. But, if you do look at averages, they're not that great. I've definitely seen a lot of success stories, and I've been very blessed to have patients live 10 plus years, but that is not the average.
So you mentioned clinical trials. What are some of the recent successes that we've seen in clinical trials in regards to new therapies for brain malignancies?
So I would say that the most successful I have seen was the Optune device, which is, Novocure, which I said it was the alternating electric field, which is actually a very great story, because it was a young doctor's thesis. I believe it's the history of it started in his basement in Israel. And it was initially approved for recurrent GBM, and now it's FDA approved for both newly diagnosed and recurrent. And that is really the only thing that's been approved. I think that it has helped in our country that we've had some very famous and powerful people diagnosed with the disease. So obviously it's been fast-tracked through FDA, a lot of the trials, and a lot of the things that have been somewhat successful on the earlier stage trials. And if you go to a center that has a dedicated neuro-oncology team, we do have some luck with getting compassionate use drugs. I can tell you that nivolumab and Keytruda, they have great compassionate use programs to allow us to use those drugs off-label. But unfortunately, we have not had any other successful trials on a large scale. We've had some off-scale patients that have done rather well, but it's not the norm, sadly.
You mentioned it, and I was thinking the exact same thing. For it not being, the most prevalent cancer, there have been, it seems to be a collection of notable people that have brought it maybe to the forefront in terms of our discussion. Senator Edward Kennedy, Senator John McCain, Beau Biden, there are names that people, not a political podcast. These are people that we know have been in the media.
They have a much louder voice. They have a platform. Let's use it, please.
Right. Well, and I was going to, just wondering your thoughts on, I know recently there's been sort of noted press, at least in maybe the nursing press, about this sort of seemingly cancer cluster of nurses in, I believe, Massachusetts.
Oh, and how they say they were all benign.
I have not read all the details of that. Certainly hearing about that makes us alarmed as an oncology nurse, just as a nurse in general. What are your thoughts on that situation?
I got maybe 15 text messages with the article. And listen, I'm from New Jersey. There was a huge cluster of cancer patients from a high school near me, all with some form of brain cancer. I happened to treat a beautiful young woman who was diagnosed at 21, and she passed away, about 18 months later. Her parents sold their house because, as her mother said, I am not losing another baby to this disease. And, her husband's like, oh, aren't we going backwards that we're selling our house and moving into an apartment? And let's keep it real. And, today's economy, trying to get another house is not that easy in our area. And she's like, nope, this is what we have to do. And again, they are saying that they can't find anything, but I think it's up to 100 cases. And I had spoke with someone at SNO, which is the Society of Neuro-Oncology meeting. I have about 25 of those samples here because we have a lab, and I'm like, let's do something with them, please. Let's do something. Let's study them. Let's see what we can find, because there has to be something. Historically, they always said there was no environmental cause. There was no familial cause. And we know now that that's not all true. We can link cases to 9/11. The VA is linking cases to exposure from the Gulf War. They are finding some genetic causes. We know for a fact lynch. If you have lynch, you're more susceptible from GBM. The science is there. We just need more research into it.
And absolutely, if nothing else, this hopefully is a perfect case of just the importance of science and research. And, we only know what we have been able to study, and we'll learn more if we can continue to study things. And so
my 15-year-old is such an empath. And I tell him all the time, I'm like, first I said, you should be a nurse. And he said, oh, you're going to not like this. But I thought nurses were girls and doctors were boys. And, after I dropped to the floor and recovered, he's like, I really like science. I'm like, so is the research. Because I've only made my kids do every walk all of their lives for all these things. But I keep telling him, I'm like, this is the way to go.
So let's talk a little bit more about our patients, of course, that get diagnosed with these brain malignancies. What are some of the unique challenges that you see your patients facing?
They lose so much of their independence, especially if they don't have a caregiver or help. That is huge. Medication management at home, to making sure that they're taking the medication properly, that they are actually taking their medication. Transportation is another huge problem. Getting to and from appointments is a challenge. Those are big issues, real day-to-day, simple issues that people don't think about. These people, they lose a lot of their functions. You know what? I had a patient the other day. Unfortunately, she had an accident in her pants. Here, we needed underwear. We needed pants. I typically keep a secret stash here, but just having donations for little things like that we all take for granted. Different language, speech therapists, physical therapists, simple things that there are not enough resources available. And that's not even getting to treating the disease.
Well, and you mentioned, there is that sort of change in independence, whether that's from the diagnosis itself, the side effects from the treatment. People who used to maybe be gainfully employed had this great job, and now they can't do that job, or they can't travel to get to that job. And so it's just this seems to be this sort of cascade of problems that just kind of compound upon one another. And that's different from, some of the other cancer diagnoses that we see. Not always. I mean, certainly other patients with cancer deal with these same issues, but I think you're absolutely correct in just the uniqueness and the sort of concentrated challenge that our patients with brain malignancies, they endure because of just the uniqueness of where their cancer is and how the treatment impacts their ability to do certain things.
And, just from a nursing perspective, we want to help. We want to do everything we can. It's challenging, and it's, Uber gift cards, whatever I could secretly do.
Do you see any other barriers that patients or their caregivers that are dealing with brain malignancies face? And what do you think nurses we can do to help address them?
I think education is really important. I think that having a brain tumor is very unique in the fact that you really need a dedicated neuro-oncologist. And depending on where you live, there are not a lot in the area. I actually had a patient that was moving out west, and the closest dedicated neuro-oncologist was 4 hours from them. Unfortunately, if you aren't a neurologist trained in oncology, you might, as much as you want to believe you're doing the right thing, it is different. It is very specialized, the brain. If you're not seeing a dedicated neuro-oncologist, you might not be getting the best treatment for yourself. So I think that having the resources and helping patients find the best care or the best brain tumor society, and there's a bunch of really good brain tumor groups to help patients find the best resources out there. I think that's really, really important for patients to know, or for families to know, just finding the resources to help them, direct them and where they should be getting treatment. And then finding even a local oncologist that's willing to work with a dedicated specialist to work together for the best care for the patient.
As we as oncology nurses are caring for these patients and their families, what are some of the primary education points that we should emphasize with them, whether it's about the malignancy itself, the treatment they're receiving, or just some general safety of how they should consider changes to their lifestyle because of the deficits we know will come with this disease?
Changes to the lifestyle, especially if someone is having seizures, I think it's very important that they know that they have to stay well rested. They always have to stay hydrated. They cannot miss a dose of seizure medication. Sugar, I think any oncology nurse, anyone going through chemotherapy, that's probably the number one question they get asked about cutting out sugars. I know I get asked it all the time. And I also get asked a lot about marijuana. So I think education, and resources. I think being able to really be able to direct patients to the people that are experts in the field are important. I think that it's also important to, if you don't know the answer, be okay with that. And I think that being able to, have realistic expectations. My own mother has cancer right now. She's going through chemotherapy for colon, and it's not something that I've ever really worked with, but she's not having the best go with it, and she's not in this state. So me trying to get in touch with the doctors, and just as a side note, my sister is also a certified oncology nurse. So she has 2 daughters in the field, and it's not easy. So trying to tell patients there are always going to be challenges, and there are always going to be up and downs, but finding that one person that they can go to, that they trust, that they have a great relationship with, whether at the doctor's office or whatever, and being available to them makes such a difference in their journey. I think that is the most important for anybody in the journey. But I really just think teaching, no matter what it is, but with brain, there are going to be expectations. They are going to lose functionality at some point, and preparing them for that thing, or, preparing them for things that can help themselves. Like sometimes they say, go to the dollar store, get coloring books, if they have weakness in one hand, little tricks of the trade that can help them, about treatment options, going through the side effects, preparing them for whatever they can be prepared for. And, like I said, clinical trials, always encouraging clinical trials.
What resonates with me, as you were describing that is, we as nurses, of course, one would hope that if I'm the nurse, I'm going to advocate on the behalf of my patient as much as I humanly can. But I think part of our role as nurses is also teaching patients how to advocate for themselves. Hopefully not with me, because I'm doing that, but when they're with other, care teams or in other situations, then as you said, preparing them, giving them the knowledge of what to anticipate that might happen or is very likely or will definitely happen. Just giving them that awareness ahead of time, that can be the biggest gift, so that they at least are not caught off guard by it. They have some preparation in place. And they just sort of know what this journey might look like. And so I think proactively helping them to kind of anticipate what's to come, especially for a disease like brain malignancies, is really important.
Yeah. I met a patient. I went to go talk to him about a trial, and, the first thing he said, he's like, well, I'm going to die. Literally the first thing he said to me. And I said, well, so am I one day. Maybe yours is going to be sooner, but maybe not. We don't know. And I was like, and I'm sorry. That's what I said to him. I'm like, I'm sorry. I have nothing else to say to you, because I knew where he was coming from, and he was right. It stinks. I knew what he needed at that moment. And that's also very important to feel it out. You know what? Having patience, I think as a nurse or as a patient, I think that it's really important to identify what they need and give them the resources. Like, you know what? Nutrition is not my strong point. So I get the dietitian there, but I have patients that are willing to talk to other patients. I look at the age group, and I think, again, being resourceful and identifying that is important. For brain tumors, I think identifying whatever needs they're going to have is important. Finding the resources, the treatment, and finding them the right treatment is so important just because it's such a specialized field.
Well, Lori, thank you so much for sharing all your great knowledge and expertise with us today. This is certainly a diagnosis that I don't think as many nurses are familiar with. And so I certainly have learned something today. As we reach the end of our episode, we like to always run through a series of just some quick fire questions to help summarize some of the great points we've talked about. So to start that off, how do you think healthcare professionals should be evaluating like our hidden or maybe our implicit bias about what it means to have a brain malignancy or to care for patients with brain malignancies?
I think that the first thing is, yes, it is not one of the better cancers to have, but it doesn't immediately mean it's a death sentence, and we shouldn't treat them like they're dying. We shouldn't take away their ability to live just because they were diagnosed with it. We shouldn't take away hope.
What are some common misconceptions about brain malignancies, aside from that one?
I was going to say, there's a lot of them. I think, especially in the news, people will always say, especially if it's a metastases to the brain, oh, they have brain cancer. Brain cancer starts in the brain. It very rarely leaves the brain. It does happen, but it is not very common at all. It's a grade 4 tumor by definition. A glioblastoma is a grade 4, not a stage 4. So that is different than, a systemic tumor, the way it is, staged. It's graded, it's not staged. And, there are success stories out there. There really are, but nothing good is really promoted as well. There are a lot of stories out there where patients use a lot of Eastern medicine. I think that we can use a combination of both medications, Eastern, Western, but one is not better than the other, and you do need both.
What's something about this topic that's not often discussed, but you wish people knew more about?
The topic. I think there's not enough discussed about it, and the lack of resources for this. These patients need a lot more resources than are available. There's just not enough available for it.
What additional training or education do you think oncology nurses need to stay current in this topic?
They need, I think, not only oncology nurses, I think doctors too. Getting dedicated pharmacology training for anti-epileptics is important. I think specialized neurology training is important. That will be my next certification.
There you go. One at a time. And what are some additional resources for patients or maybe other providers who want to learn more?
A really good way to start is any of the brain cancer foundations. Not that I want to point out one over the other, but the Macella Foundation really does send out for free a brain tumor guide book for newly diagnosed patients. It's excellent. The End Brain Tumor Foundation, which is Dylan Elliott. She also has she has webinars on her website. They're really great resources, and they send out books up to date. The Macella one is on the 12th edition. And I think it's important to ask patients what they can handle and when.
Well, Lori, thank you again. We'll be sure to try to include as many of those links in our episode notes as we can, just to share with our listeners as well. Thank you so much for your time today and sharing all of your knowledge with us. Do you have any final comments to share with our listeners?
You know what? Anyone can feel free to email me with any questions that they may have. You're more than welcome to share it. And it is a topic I'm very passionate about. And if anyone has any ideas or anything, I would love to hear them. Any research project, I love it. So
wonderful. Well, thank you again.
Thank you.
Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.